Well, good evening, everyone. Welcome to the August ASJ Journal Club presented by the Young Aesthetic Plastic Surgeons Committee. Tonight we'll be discussing the article, Progressive Improvement in Mid-Facial Volume, 18 to 24 months after simultaneous fat grafting and facelift, an insight to fat graft remodeling. So a couple brief reminders before we get started. Please mute your microphones, number one. And number two is we want to try to make tonight as interactive as possible. So please, if you have questions, enter them in the chat box, or even better, we encourage you to hit the raise hand button, which can be found on the participant list. And after Dr. DelVecchio is finished, I'll call on you. It'd be great if you could turn on your video, ask a question, or just share your experience or make a comment. We definitely want to hear from you. All right, so tonight we have the honor of having our author, Dr. Steve Cohen, join us. Dr. Cohen's in private practice in La Jolla, California, and he's a clinical professor at UCSD. So after his plastic surgery training at Penn, he did a craniofacial fellowship at UCLA, and then was the craniofacial director at Michigan, and then at Atlanta Children's Hospital. He's a true leader in regenerative plastic surgery. He's on the ASJ editorial board, and he's won the ASAP's ASURF Tiffany Award for Best Scientific Presentation for this very paper we're discussing tonight. So thank you so much for joining us tonight, Dr. Cohen.
Thank you, Mark. I'll go ahead and share my screen.
All right, give me 1 second. Let me just tell everyone a little bit about Dr. DelVecchio, and then we'll have you share your screen. So Dr. DelVecchio is also joining us as our discussant. He's in private practice based in Boston, Massachusetts. Dr. DelVecchio attended Harvard Medical School and MGH for his residency and did cosmetic fellowship at Penn before an MBA at Columbia. So he's considered a pioneer and an international authority on fat grafting, having written numerous articles and book chapters, and he actually also won the Tiffany Award the year after Dr. Cohen. And thank you, Dr. DelVecchio, for joining us tonight.
Thanks, Mark.
So Dr. Cohen, please feel free to share your screen, and we look forward to hearing your insights about your article.
Okay. It says host disabled attendee screen sharing, so whoever the host is, I don't know, are you guys seeing my screen yet?
Not yet, but I think
Dr. Cohen, I just made you a co-host, Dr. Cohen. Hopefully that will enable that.
Let's try that. There it goes. Okay.
Okay, good deal.
All right, let me just. Well, thank you very much for having me, Mark. And hi, Dan. I hope everybody's well. This is the article that we were going to discuss, Progressive Improvement in Mid-Facial Volume 18 to 24 months after facelift and fat grafting, and insight into graft remodeling. And just want to acknowledge my co-author, Sierra Hewitt, who is just graduated from UCSD and will be attending Stanford Medical School, and Lauren Ross, who has worked with me over the summers, Michelle Fisher, our nurse, Dr. Ahmad Saad, who practices in Barcelona, my former associate, Savannah, my scrub tech, and Flora Delaney, who practices in Rion, France. And Mark already mentioned where I'm from. These are my disclosures. They will not affect this talk. So just a little bit of background about fat grafting and facelifts in general. I just want to kind of comment on three things. One, acknowledge the biologic activity of fat. Once the fat cells are eliminated, we're dealing with stromal vascular fraction, which is a huge repository of stem and regenerative cells. Two, I want to acknowledge the and recognize Joel Pessa, Rod Rohrich, and Val Lambros for really not only the recognition or the rediscovery of the anatomic fat compartments, but Val giving us insight into how they age. And lastly, I want to just mention that I've been a huge proponent of trying to look at anatomical changes over time that produce laxity and some of the other associated conditions with facial aging.
Dr. Cohen, can I interrupt you for 1 second? Should we be seeing your screen right now? Did you share it with us yet?
I did.
Okay, I don't think we're seeing it quite yet.
I don't know why. Hold on, let me see. I'm going to share it again, but oh wait, let's see. Here we go. Are you guys seeing it now?
Yes, we are.
Okay, thank you, Mark. let me just go back. So, okay, so I mentioned that I want to just kind of give you some background on biologic activity of fat, just recognition that there are discrete anatomic fat compartments both above and below the muscle that have variations in aging depending on the patient, and then just the various anatomic changes in the midface that produce laxity. So, you know, the biologic activity of fat has been well recognized. Really starting around 2001. So in spite of all of the amazing work Sid Coleman has done, Richard Ellenbogen and others in fat grafting, it was really not until 2001 that people began to look at the possibility of human adipose tissue being a source of cell-based therapies. And stromal vascular fraction, for those of you that are not familiar with this, is really, you know, it's everything minus the fat. So once you eliminate the fat, the matrix has a host of cells, and when these are obtained enzymatically, you're getting really kind of a serosanguinous cellular mixture that's been termed stromal vascular fraction. It's a mixed bag, so stem cells really only account for a very small percentage, although relative to bone marrow, if bone marrow has 5,000 cells per milliliter, fat has 500,000. So still a huge repository, and a lot of undefined stromal vascular fraction cells that we're still not 100% sure what they do. We do know that these stem cells have associated with them a very large number of growth factors, cytokines, chemokines, and other kinds of factors that influence repair, modulate wound healing, and even help with immune modulation. We also know that when they're injected, there's kind of a cascade effect where these growth factors can be assayed even out to a month. And I suspect if studies were carried longer, perhaps even longer. So these effects go on for a while. And the benefits, as I said, of SVF and nanofat, which is really kind of a marketing term for SVF or a different type of SVF, is one, neoangiogenesis, two, collagen and elastin remodeling, and three, immune modulation. So some of the early studies that were done, this is actually the first woman injected with cell-enriched fat back in 2003. And this is 6 years later, and you can see that the effect on the radial wrinkle lines of her lip is fairly pronounced and long-lasting. Same with the nasolabial folds. And what's interesting, only the folds and the actual vermilion portion of the lip were injected. So these cells have a way of homing to areas of injury. If you look at this lady who was also in this study, it almost looks like in the pre-injection picture, she's like a wilting flower. And in the post-injection, it's almost like the flower is woken up. So to some extent, training our eye to see these events is very similar to, at least myself, when I first started using filler and Botox and lasers. It takes a little bit of time to accustom one's eye. These are not surgically magnificent changes. These are more subtle changes that can be assayed histologically. You can see the pigment change around the eyes on this woman, not always predictable, but confirmed by excellent histologic studies from experiments out of Brazil and Italy, primarily from Gino Ragotti's group, showing a reversal of age-related changes in elastin fibers, collagen fibers, and again, quite a bit of new neoangiogenesis. So set that aside for a second and just assume there's biologic activity in conventional fat grafting. Two, recognize that there are specific compartments and how they might behave with aging. So there are compartments that are associated with the skin that are superficial to the muscle. These are tightly composed and they tend to be supportive of skin health. Whereas the deep fat is really primarily loosely organized and is primarily allowing the muscles of facial expression, which are not attached to bone, to move and glide within the face. So they're different purposes and they're different structures. The structure of superficial fat, or the assembly of these parcels are very tight, like cobblestone streets or pureed applesauce. The deep fat, as you're familiar with, is more billowy and cloud-like, as you can see in the buccal fat. Now, with aging of these fat compartments, which happens differently in different patients, there's combinations of both dropping of the compartments as well as actual atrophy of these compartments. And whether or not they affect the underlying bone, because as you lose the functional matrix, the bone loses some of the signals to it. One of the theories is by that reduction of functional matrix, it's kind of the reverse of growth and development. It's really kind of unfortunately aging and decay. So one of the things that we do with our fat grafting during the facelift is we make 3 types of grafts. We make a more structural graft that's anywhere from 2 to 2.4 millimeters. We make a more microscopic graft for superficial compartment replacement that's 1 to 1.2 millimeters. And we use a nano fat that, again, is, in this case, is a minced cell aggregate. So you're actually preserving the fibrous tissue, not filtering it out, but mincing it into smaller sizes so you have more cells. And again, these are placed deep below the muscle, superficially in compartments of loss above the muscle, and then the nano fat is used more as a regenerative product in many different ways. So if we look at, in general, fat grafting, you know, all of you are familiar with this. It's an 18-gauge needle puncture. I'm filling the pure form, and then I'm doing the deep medial fat, and then I'm going to slip up to the medial SOOF and the lateral SOOF. And this will allow me to do the cheek, which is really the focus of this facelift paper today. So this might be the cheek. And when we're doing buccal fat, the simplest way to put this in a woman, for instance, like this, who've lost buccal fat pad, is through the same incision that we fill the lips. We go submucosally and we puncture through the buccal muscle, and we're in the deep buccal fat space. It's very simple and very direct. When we're doing eyelids, this is very important because here we're simply topping off the superficial aspects of the SOOF. So we're below the skin in the superficial fat, but you notice we're not in the eyelid. Okay. When we're putting in nano fat, we're actually now in the eyelid itself. So this is a cell product. There's no fat cells in this. There's just stromal vascular fraction. And you can see I'm actually going to be inside the lid above the orbital retaining ligament. So we're not putting fat in there because there is no fat there. We also insert nano fat with a technique that Alex Verpalli and Patrick Tenard described, which is basically called sniff. I do this with a computerized device, and we're putting this intradermally. And the last component intraoperatively is microneedling with this device that delivers the nano fat 1.5 millimeters into the skin. And finally, as part of our protocol, we send the patients home with a biocream, which is the subject of another paper that is being published in the journal. But basically, this is compounding the nano fat with lipoderm, which is a liposomal agent that allows transport of molecular weight Dalton units 5,500 and less, so smaller growth factors, into the skin, and the patients go home with that. Now, what about the facelift? So the facelift, in my opinion, the fat replaces lost fat. In my opinion, what's happening with the facelift is the ligament attachments of the face. You have true ligaments that go from the bone directly to the undersurface of the skin. So like the orbital retaining ligament is a true ligament. The zygomatic ligament is a true ligament. The mandibular cutaneous ligament is a true ligament. However, the mesenteric cutaneous ligaments, even though Brian Mendelsohn had mentioned these as true, really arise from the mesenteric muscle fascia, and they're not attached to the bone. These are really the only ligaments, I think, that are capable of stretching because they're not attached to bone. Whereas, as you know, to cut the mandibular ligament, to cut the The zygomatic ligaments, they're difficult to cut, whereas the mesenteric ligaments allow basically a rotation of the mid-face downward and outward, so laterally and down, which produces your jowling effect and has some influence on the neck. The neck is different, it's a different story. So when you start to think about repositioning with the facelift, and one of the reasons the deep plane is chosen is, I'm sorry, maybe somebody's got potato chips or crackling, but if you can hear me, the deep plane is chosen is in order to rotate this back up in a vertical and to some extent medial direction. So that's the rationale for the facelift. You can see where these ligaments are attached. These are true ligaments attached to bone, whereas these ligaments in the premesenteric that I'm separating with this Trespat elevator are false ligaments, and these are the ones that stretch. So again, fat grafting augments volume, regenerates tissue, the facelift repositions, and also recreates support for the deep neck structures. So if we take this woman who's 63 years of age and we go, what are we going to do to her face? We're going to do a deep plane facelift. We're going to do this anatomic and regenerative fat grafting that I showed you. And we might be doing something like this. This is actually her treatment plan. So the deep structural fat went in where the purple is. The microfat was used in the areas of the green. The nano fat was microneedled throughout the entire face, and the amounts are given in the data sheet. And then a year later, you can see the combination therapy. The next patient, the same kind of thing. You analyze her. Here's where the deep fat is going to be used, or the structural fat grafts below muscle and for bone, the superficial and the nano fat. And again, combined with the deep plane facelift. So when we looked at this, what we started to do is, we've been following these patients. Very difficult to find aesthetic patients sometimes to get follow-up at 1, 3, 6, 12, 18, and 24 months. But we were able to get a handful of patients. And we have basically followed them over 18 to 24 months after the deep plane lift with an anatomic regenerative fat grafting approach that I showed you. The average age was 63, the range was 52. Actually, I had one patient 85, but physiologically more like 67. There were 6 females, 12 hemifaces, and they received deep and superficial compartment fat grafting, including to the buccal face, and this is the group that forms this report. And here's how we followed them. And what we did was we basically looked at overlaid and aligned images to determine volume changes in a specific area of the midface. And when we did that, there are some representative examples. A 52-year-old woman, 42 milliliters of fat were injected, and gradually you can see, and I'll show you her curve in a second, you can see that there's even a little bit of dropout in B, and then there's reaccumulation of fat in C. And what's interesting is, in these patients, not a single one of them actually had gained weight. So there was no change in weight over this 24-month period in any of these 6 patients. So the data is relatively tight for this kind of study, albeit small numbers. So once these were measured, some of the representative curves for the first woman looked like this. She had about 100% at about a month. She had about a 50% improvement. She gradually started to diminish from 2 months up to about 9 months. And after 9 months began to, again, show evidence of facial volume improvement. These were surprises. I mean, I had no expectation other than that gradually the volume would disappear. But interestingly, in the vast majority, well, 67% of patients, these were the kind of curves. This is actually the second patient I showed, and her curve, you can see a diminution to 7 months and then a gradual recovery starting around 10 or 12 months out. So that was kind of interesting. A small number of patients did just gradually lose facial volume over the course of time. And it was unclear whether they had any differences because this was a very small study. But 67% of patients showed very similar to curves with actual improvement and increase in midfacial volume over the study period. So we started with about at 1 to 2 months, about a 59% improvement in facial volume with the combination techniques in the mid-face. And by 2 years, we had about a 74% improvement. So we actually were seeing some evidence of trophism. And our conclusions were, obviously, this is a very small study. Other people need to verify it. Some of the positives of the study, this was a very standardized technique. And because of that standardization and because these patients were relatively tight with no facial weight gain, we thought that these observations may be valid. And in some ways, they support some of the studies that we've done and others have done looking at how fat regenerates. So with Yoshimura, one of his main comments is that the fat actually dies and gradually the stem cells that are hardier and survive low oxygen tensions gradually replace the fat. Of course, there's a small outer rim of about 300 microns where the fat survives, but most of this is gradual replacement. And then as the fat accumulates a blood supply, it plumps up and develops some hypertrophy. How do these approaches affect younger patients? Because this was my real interest. Are we able to modify how people change or how people age? In other words, rather than looking at fat as a natural filler with so many of its advantages, looking at fat as potentially an anti-aging therapy. So if you have a woman who comes in like this at age 30, requiring more than one filler, why? Because she's lost volume. Volume is not air, it's specific tissue, specific anatomic changes in those tissues. So if you can diagnose that from the topography of the face, and you can take her and put in deep fat in the purple, superficial microfat in the pink, and nano fat in the green, what happens is 6 months later, a year later, you begin to almost reverse the picture. It's not that you're changing her appearance other than making her appearance more youthful and similar to what she looked like at a younger stage of life, because you're it's like changing the carpeting, and yes, it will get worn again. Another example of a very similar approach, pan-facial fat injection in all areas, very similar to that young lady, and you can see the changes that occur. Now, this is new, and I'm only going to wrap it up with this. What about these patients? Well, it looks like when we put all of them together, all ages, they almost seem to be developing similar curves with an early, volume improvement, gradual diminution, and then some recovery. When we took out the patients less than 55 years of age, it was actually very pronounced. And when we looked at the patients greater than 55 years of age, they were showing very similar trends to some of the patients I showed you who really were not failures, but the group that kind of gradually diminished. So really, the question I'm asking is, here's a woman, 6 years of normal aging from 2011 to 2017. Here she is 6 months after her treatment in 2017. Here she is 2 years later. But this is now 8.5 to 9 years, almost 9 years of aging from 2011 to the last photo. I think we're starting to change the way these people age in a very realistic fashion. And if you think of nuclear decay being loss of mass over time and the rate of that loss being the rate of nuclear decay, perhaps it's similar for facial mass decay or facial volume decay. So thank you. That's kind of the article and some of the background and some of the directions that we're taking. Thank you very much.
Thank you very much, Dr. Cohen. That was great. So now we will turn it over to Dr. DelVecchio for his comments. Let's just unmute Dr. DelVecchio if possible.
Thanks, Mark. Congratulations, Steve, on your publication. I think it's important for people who are on the call to appreciate that Steve's paper really is a culmination of 30 years or more of craniofacial surgery, facial cosmetic surgery, and a large amount of research and experience with stem cell therapy, SVF, PRP, fat, as well as other modalities. This paper, in many ways, reflects Steve's experience. Craniofacial surgeon. He actually taught me a craniofacial course when I was a young plastic surgeon in Toledo, Ohio. I first met him there. He was teaching me craniofacial. There was a craniofacial course. I think his review of the facial fat compartments, the retaining ligaments, and nano fat, millifat, microfat is extremely well done, very clear. He also talks about the skin. I mean, if you think about this paper, it is a very brief but clear and pretty succinct review of dermatology, craniofacial aging, stem cell treatment, fat grafting, and surgical facelifting. So I think that was extremely well done, and it's not easy to do that in 4 or 5 pages. But it is a reflection of Steve's experience. The level of evidence on this paper was level evidence 4, therapeutic. It was 6 patients. I think there are 2 ways to look at this paper. One is to look at this paper as a review of facts and a hypothesis that demonstrates by these 6 patients that there's definitely the possibility or the potential for SVF to reverse aging or to at least halt it. The main proxy for that is the increase in volume. It's not, gee, these patients looked younger because obviously they had facelifts, but the quantitative scientific part of this that gives credence to the hypothesis that SVF can somehow reverse cellular aging is volume increase. So looking at it as a review, I think it's an amazingly good and very succinct review. Looking at it as a argument that SVF reverses facial aging, and nobody made this claim, Steve did not make this claim, so I'll preface it by saying that it definitely needs to be corroborated. There's an amazing amount of research that could stem from this to try to isolate the variable of carpeting that Steve talks about, or intradermal nanofat, or the introduction of SVF into the dermis and subdermis, to actually prove this concept. I don't think this paper proves the concept, and I don't think Steve is saying that this concept is proven. However, I think that there's a huge amount of basic science or even clinical research that could be done to try to isolate the treatment. In other words, these patients had incredibly good surgery. Some of them had fractional laser therapy. They had microneedling with the introduction of nanofat. And it's kind of like Aristodemus presenting at scientific meetings where he does, Brazilian butt lifts, and he adds SVF and he says, my patients look great. Well, my patients look great too, but I don't use SVF. So where's the isolation of the variable? And so I think what needs to be done here is that one needs to look at the isolated variable of the carpeting, the intradermal insertion of nanofat, and then some type of biopsy has to be done to look for, new collagen formation, increased capillary density, thickening of the dermis, the proxies for aging that we would value as proof of halting or reversing aging. And just off the top of my head, I mean, I think that a really interesting way to do that would be patients who are having abdominoplasty. 6 months before or a year before, you could probably suction some fat out of them and do some facial fat grafting, and then do some microneedling on one side and some microneedling on the other side, and include nanofat. Because there's no question that microneedling in and of itself, just like Fraxel laser was a decade ago, or microneedling 5 years ago, RF microneedling with no biologics, had an improvement based on the injury and the repair of the tissues. So your real isolated experimental clinical study would be abdominoplasty patients with striae and aging skin in their abdomen, one side microneedling, the other side microneedling with nanofat, and then at the time of the abdominoplasty, biopsying them. That would be a very interesting thing to do, and I think this paper is the launching pad for that, to really prove whether this is just a great result because you have an experienced surgeon who can get great results, or whether this incremental carpeting that Steve has talked about really has an effect.
Let me ask both of you, if you don't mind, is there any reason we can't extrapolate this concept to other parts of the body, like the buttock, for example? I mean, has it ever crossed your mind where a year after surgery, you think all of a sudden you have a little bit of an increase in volume you didn't see months before?
Well, I don't think Steve is talking about volume here. I've been following, Steve and I have known each other for a while. I don't think Steve is talking about SVF to increase volume maintenance. He's talking about looking at the face as a recipient site for multiple types of fat grafting. Regular fat, millifat, nanofat. He's talking about the, right on the bone where Rod and Pessa talked about the compartments. There's no need to put nanofat there. You want to put big lobular fat in there. You want what, Mike Yaremchuk puts facial implants in. You can probably build up the malar midface with large volume fat. And he's trying to articulate that you can't just talk about fat like gasoline. Like there's high test, there's medium grade, there's low test, there's nanofat, millifat, and regular fat. And Steve is saying, let's not look at the face like some recipient site for fat grafting. We're not just pumping fat in someone's face. We're putting large lobular fat deep on the bone by retaining ligaments, and in the subcutaneous tissues, you're going to put millifat, and then intradermally, we're going to put nanofat, not for volume, or SVF. You saw him using SVF. It's not for volume. You're not trying to increase the volume of that recipient site. You're trying to introduce stem cells and SVF into the dermis to try to create a regenerative environment. So I think that all makes sense to me. My comment was about what to do next. Now, in the buttock and breast, nobody looks at the skin of the breast and says, gee, that skin is really, it's got lentigos and wrinkling and it's got age spots, because frankly, we cover our breasts and buttocks and there's not a lot of sun damage on them. It's really 99% a volume game. That's why we do breast implants and buttock implants and fat grafting. And I think it's a much less complicated recipient site than the face. The face is a much more complicated recipient site. It has skin that's visible all the time. That skin can have sunspots, wrinkles, loss of elasticity. The buttock and breast are much more pedestrian recipient sites, in the sense that the success of those procedures is volume mainly, is establishing volume. And I think, Steve and I have looked at fat grafting for years in large volume and thought about augmenting the fat with stem cells. And I think, largely that kind of quest after, I would say, at least 15 years now, I think that quest is dying down. I mean, 10, 15 years ago, we would see papers and whole like panels on stem cell enriched large volume fat grafting to the breast and buttock. And I think you rarely see that. Those days are gone. I think that the volume of SVF you need to get a clinical result, the dose response effect is so high in a world without processed stem cells and clonal replication of stem cells ex vivo. The amount of fat you need to process to get that stem cell volume is prohibitive. And I would be interested in hearing what Steve's current feeling is about that. But I think that in these small volume cases, and I wrote a paper called A Clinical Classification of Fat Grafting, and it basically says different problems, different solutions. In the face, in Raynaud's, in scleroderma, in venous ulcers, in scar, we definitely see evidence of SVF and even nanofat having a positive effect on regeneration. And I think it's not because of the disease, it's because the volume needed is much lower to get an effect, because the recipient site pathology is small. You've got a venous ulcer, you've got someone with scleroderma on their skin. It's a small problem. Now, the face is not that small, but it's a heck of a lot smaller than a breast or a buttock. And I think that what Steve is talking about, it makes sense because we know that stem cells do have an effect, but they need to have a certain dose. And I think the face is a place where you don't need that much SVF or nanofat to get a result.
Thank you. Dr. Cohen, thoughts, if you don't mind.
Well, I think I appreciate what Dan's saying. Yes, both of us have been around this for a while now. And one, on the large volume, I agree with Dan. One, anatomically, if you look at the buttock, which he's done tremendously well, you're really dealing with the superficial layer and a deep layer. And, to some extent by, for instance, filling the deep layer like Pat has shown with, ultrasound, perhaps, you get more of a core projection. So, there's some importance, at least in where you're placing the fat to some extent. But in the face, it's different because if you use fat as a filler and you fill up, for instance, the buccal area superficial to the muscle, those are the results, in my opinion, that people show where these people gain a little weight, the tissue looks thick and ugly because there's not fat like that in that area. So why, as surgeons, are we anatomically doing something purely non-anatomic, just aesthetic, when we can put it in the right compartments in a very simple way? This is not really as challenging as people think it is. I mean, it's not so precise that, you don't put it in the deep medial fat and think, oh my God, it's going over here. It goes and fills up one little area. You move it, it fills up another area. So it's fairly specific and it's more anatomically oriented. Two, I think what Dan's saying is right. I mean, this is a little insight into remodeling. And in my opinion, if one thinks about decay and if one thinks about growth and development, we really have a functional matrix that kind of leads our bone growth. And as that diminishes over time, I think it also begins to influence our bone atrophy or loss of bone. And I think these kinds of things with aging, if we start to think more dynamically and more anatomically, not just aesthetically, this looks nice, but why are we doing this? And what is truly the appropriate treatment? For instance, yes, you get a very nice result with a mastectomy. Yes, I agree, aesthetically it looks pretty, but if really what's happening in most patients are stretching these ligaments, why not do a deep plane and put them back? So I try to think anatomically, and I think that's the most important thing. So varying the fat for more structure, varying the fat, if nothing else, for safety. You want smaller particles, more superficial. You don't want to see bumps. And nanofat is purely like a poor person's SVF or a good marketing term. You know, it's one type of mechanical stromal vascular fraction. And there have been enough studies now in animals and humans to show that these kinds of device or techniques, and they are dose dependent, will absolutely reverse some of the changes, but it's subtle. So that's why I start to advocate, you know, thinking about doing this anatomically in younger patients when they're coming in for more than one filler, because that's the opportunity to really start to perhaps modify their curve. And again, this is my hypothesis, and clearly I need others, you know, I mean, I don't have a lab set up, and I'm missing a lot of aspects of this, as Dan pointed out. So this is really meant to be like, here's a glimpse into remodeling, and others maybe can pick up on this concept.
Great. So we have a number of questions waiting we want to make sure to get to. If anybody wants to chime in by video or audio, hit the raise hand button, please. We have a question from Indonesia. How do you predict the absorbed volume of millifat, microfat, nanofat, and is there a way to prevent the absorption? That was for Dr. Cohen.
Well, here's again, I don't think that's that important. I think here's my theory is, if you're doing the same standardized technique and you get absorption in some patients and not as much in others, you also have to recognize we're dealing with their DNA. You go to your high school reunion, some people, you look at them and you go, shit, I hope I don't look that age, because they've prematurely aged. Their cells and the way their cells interact with the environment are different than somebody you go, wow, look how great they look. So now you're dealing with genetics. And so when you really look at this, it's a very complex multiple regression analysis that needs to be done, and some composite of aging that you begin to start to think about. And I think these new aging therapies are going to start to become very, very popular in the future, you know, even intravenous uses of stem cells and things like that. But I think right now, if we start to think not just aesthetically, what can we do to improve people, but how do we actually alter their aging? One, it brings patients back in your office, so it makes total financial sense. Two, it doesn't eliminate fillers, because now you're telling people, use a filler for an aesthetic pop, but use this kind of concept to actually return the functional matrix you're losing, to maintain your bone health, to delay or prolonged aging. And those are the things that I hope more insight will be gained with these kinds of approaches, Mark.
So our next question is, if the late volume gain is secondary to stem cell induced fat growth, why not just inject SVF?
Some people might argue that you should, but again, I look and I say, I got tired of these arguments about SVF and stem cells, because I agree with Dan. One, it's so hard to prove that there's some major effect. And to me, it seemed like a marketing term for a subject that's too important to be a marketing term. So I went back and I started thinking, let's just think about basic fat. And, you know, one, if nothing else, if we treat it like a filler, we want it to be certain sizes to produce certain effects. Two, anatomically, it makes sense. And the nanofat, as I say, is really a poor man's way of creating regeneration. The microneedling definitely has an effect, but in studies we've done with fractional lasers, with and without nanofat, we've had significant improvement in outcomes with the addition of the nanofat, with only 3-day applications twice a day. So I think there's some real validity to these things. And I think Gino Rigatti has shown some beautiful histologic studies in patients undergoing facelifts where he's added mechanical SVF with fat, and he's biopsied them at the time of the facelift, much like Dan wants to do with, you know, with tummy tucks. And he found, you know, histologic reversal of changes in elastin, collagen, and in blood supply. It's a terrific study.
Great. And Manish Shah has a great question. He's wondering whether volume loss in the over 55 cohort could be related to the postmenopausal state. In other words, does hormone support play a role in volume sustenance?
It sure might. Yeah. And that's, again, you know, that's a study right now of about 30 patients. So it's not a giant study, but it's a reasonably decent insight. I mean, look, Sid has been looking at this stuff for, 25 years, but we don't have any real prospective information about what's actually happening to these fat grafts. So yeah, I think for sure in the older age group, there may be other things that need to be, considered.
All right, and Alexandra Schmidt is wondering, what microneedling device do you use for the nano fat, and can you describe the SVF lotion that you make for patients?
Okay, so I use a microneedle that's 1.5 millimeters in length. It's a stamping technique rather than a rolling technique. And there's one in the US called Aqua Gold. And the one I use is bought on the internet, and it's called a Hydra, Hydra needle. And, that's what I use. It's basically very similar, but less expensive. The compound for the NanoFat Bio Cream, the way I do it is we spin the NanoFat, with us in a centrifuge for a few minutes, I think at 3,000 RPM. It makes it a little more gel-like. We get rid of the extra fluid, the free fatty acids, and now we take that and mix it 1-to-1 with something called Lipoderm. Lipoderm you can get from a compounding pharmacy. It's a device that is used to, enhance delivery of certain medications transdermally. So it'll bind Dalton units, molecular weight Dalton units to 5,500 or less. So smaller growth factors, not stem cells, but smaller growth factors and certain particles that we probably don't even know. And it'll transport it through water-soluble tissue, of which skin is 95% water or something. And that's the effect of that. And we put it in the refrigerator. The stem cells actually, if there were any, but the growth factors survive at 4 degrees, Fahrenheit. So this thing's active until I think it's finished. And we compound it with arnica and a little cucumber so it smells good. It doesn't smell like rotting fat.
Great. And this is the last question of the night. This actually came in from email from Ellis Tavine. Could the author and the discussant elaborate on the technique they use to process and transfer the fat? And then he says, viability can be affected by the technique.
So the viability, we happen to use something called NanoCube, and just by disclosure, I'm one of the co-inventors along with Tunç Teriyaki and Kai Yui Schlauroff and Mickey Shefflin. So what that does is it minces the fat rather than like Tulip filters it. And when we looked at our studies, viability of both Tulip and this technique are 97%. In terms of cell counts, we have about twice the number of cells, which makes sense because if you filter the fibrous tissue, that's the matrix, that's where the cells reside. So if you chop it, you're still able to inject it through small needles, but you maintain the cell niche or the fibrous tissue. I think that may explain it, yeah?
Dr. DelVecchio, how do you process your fat?
Large volume fat?
Both. And if you're injecting in the face, how would you do anything differently?
Well, yeah, I mean, I definitely will use nano fat in the face. My source of it is different. If you suction a lot of fat, and I've shown this slide a million times, but if you suction a lot of large volume fat, you'll see in the canister it separate into at least 3 layers. One is just blood and water, and the other is oil at the top. And then below the oil, you have the largest lobules of fat have the least density. But right close to the crystalloid layer, you'll see, and it varies between 1 millimeter and could be 3 or 4 centimeters, depending on how small the lobular fat is, depending on the patient. You'll see literally like small, tiny particles of silty fat. And so that makes sense because when fat is extracted, it's going to extract on a continuum between one single cell and a cluster of 600 cells. It's like grating cheese. Not all the cheese comes out the same size because some pieces are way smaller than the grater. just like some pieces of fat are way smaller than the 2 millimeter diameter hole that Steve showed in his article. So instead of manipulating the fat with a mincer or a nanocube or the tulip device, or what Tanad did was, he put it through a nylon stocking, I simply just take that small lobular fat, and that's the quote high density fat that Sid Coleman talked about in his paper. He talked about high density versus low density fat. The density of fat is a constant. I think Sid kind of could have called it small lobular versus large lobular fat, because small lobular fat has more stem cells on a per cc basis, but it's not more dense. It's just that the cell membranes have a higher proportion per volume, and therefore they sediment out at a lower gradient. But that's the fat that I use in the face, and I'll put it in the dermis and I'll carpet it. And I think, I learned that from Steve probably 2 or 3 years ago. And, I don't do enough facial work as Steve to appreciate what they would look like if they didn't. And it's kind of, for me, it's kind of an add-on. If some 45-year-old wants a BBL, I'll try to, suggest to them that they could have some facial carpeting with the nano fat. And I'd probably do that in 25% of my 40 and up BBLs. But I would tell you that I think Steve's method is pretty, I have no problem with it. That's the way I do it. It's just that the source of the nano fat is different, because it's like I'm taking so much fat already. There's no need to suck out fat and disaggregate it. Does that make sense?
Mm-hmm. Absolutely.
Steve, question for you. That replacement for that aqua gold, was it called Hydra?
Hydra needle, just HYDRA.
And is that a prong like the?
It's the same device, Dan.
And is it a hollow needle, or is it the groove needle like the aqua gold technology?
I think this is a hollow needle, but there's another one out of France, and I have a feeling the Koreans knocked that one off. There's one out of France. I'm just having a hard time finding it again. That is the exact same thing, patented.
Yeah, I mean, I would think that a hollow needle would get you more product intradermally by capillary action. The aqua gold needle is a bunch of gold needles, and externally it has a spiral groove that the product, be it SVF, growth factors, it could be anything, goes in through the groove, as opposed to a hollow needle. I would love to see that hollow needle. I'm going to look it up now.
All right. Well, thank you both so much for your time. This was really an excellent night, excellent conversation. I also want to thank ASJ Managing Editor Hunter Alexander for making tonight such a success. Thank you, Hunter. So everyone tune in September for the next journal club put on by the ASJ Next Generation Editors. And back in October, we'll return for the Young Aesthetic Plastic Surgeons sponsored journal club. Have a great night, everyone. Thank you so much. Bye-bye.
Thank you, Mark. Have a good night. Take care. Bye, Dan.
Bye-bye. Bye-bye.